Hello everyone, I am Dr. Richa from Physiology Open, and in this video we will continue with our Pharmacokinetics series. This is lecture 5 on drug elimination. So this aspect of first pass metabolism we have not covered in the previous video, so just let me finish this. What is this first pass metabolism? When you give the drug orally, so it is absorbed in the intestine. So say suppose this is the intestine, it is absorbed in the GIT and then via portal circulation it enters into the liver. So that is normal physiology. Anything which is absorbed first it goes through the liver, and liver is like a scanner seeing that what is the foreign substances there and anything to be protected from. So it removes everything from there. Now these drugs also they are metabolized when they enter into the liver. So say suppose in the portal circulation the concentration of the drug is C1 and when coming out of the liver the concentration of the drug is C2. So if we subtract these concentration, that is C1 minus C2, and divide it by the original concentration, this is known as the extraction ratio. Okay, so that means this much amount of the drug has been extracted by the liver, it has been removed by the liver, that is prevented by the liver from entering into the systemic circulation. Okay, so this affects the bioavailability of the drug since it has already been removed. Okay, so any drug which has a high extraction ratio, that means it has been removed by the liver, the oral dose required for that drug will be much more. Secondly, the dose variation for this kind of drugs in different people is much more because the amount of the drug which is removed varies from person to person. We have seen in the previous video how there is existence of genetic polymorphism, that is the enzyme activity or the amount of the enzymes which are responsible for metabolism varies from person to person. So this also leads to dose variation from individual to individual. Thirdly, liver diseases. If liver diseases are there, then this extraction ratio will decrease and this is going to increase the bioavailability of the drug. So we have to be aware, since again this is going to affect the dose of the drug. And finally, there can be competition between the drugs. So suppose there are two drugs which are being metabolized by the same enzyme. Then in that case, if they are entering into the liver, then which one will be metabolized depends on the substrate interaction with the enzyme. Okay, so there will be competition between the two and that will affect the metabolism of one or the other drug. Okay, now moving on to the elimination part. So what is this drug elimination? Drug elimination means the drug is being removed from the body. Okay, and the main organ is kidney. Okay, so we have seen in the previous video that with drug metabolism, what happens that lipid soluble drugs are made into lipid insoluble, or we can say water soluble drugs. Okay, now this water soluble drugs are mainly excreted by the kidney out of the body. Some of these drugs, the metabolites which are there, if they are large molecular weight, then actually they should filter, no? When they are reaching to the kidney, they should filter at the level of the glomerulus and reach to the Bowman's capsule. If the size of the metabolite is much larger, then that is not going to happen. So in that case, that large molecular substances enter into the bile and they are excreted via the feces. Also, you have given the drug orally. Okay, so some percentage of it is absorbed, the rest of the percentage it is moving into the feces. So feces, what is going to happen? Large molecular weight substances plus the drug which has not been absorbed, which is given orally. Okay, then moving on to lungs. Lungs, obviously, if the drug is a volatile liquid or gases, for example the anesthetic drugs, they are being removed by lungs. Then sweat and saliva, quantitatively these are not much important. That means the amount of the substance which is excreted by this is much lesser, so not significant. Then milk. Yes, some drugs can pass through the milk. All in fact lipid soluble drugs can pass through the membrane and enter into the milk. In fact, when prescribing to lactating mother, we have to make sure that it is safe for the neonate. In fact, quantitatively if we see, it is not that important. However, yes, it can affect. Also, it is the basic drugs which accumulate more in the milk. This is the same concept which we saw in drug transport mechanisms. Actually, the milk pH is acidic. Okay, So what happens, say suppose this is the membrane and this is the basic drug which crosses the membrane. So as it enters into the acidic environment, what will happen that here now it will become more ionized. Okay, after entering it will become more ionized and it will be trapped in that milk. Okay, so that is accumulated in the milk and passed on to the neonates much more compared to the acidic drugs. Okay, now moving on to the fundamentals that how the drugs are excreted in the kidney. Well, this is the fundamental basic mechanism of excretion of any substance, that if the substance is of low molecular weight and can be filtered at the level of the glomerulus, so from the glomerulus it will filter into the Bowman's capsule. So F is for filtration. Then some of it may be reabsorbed, so that is tubular absorption, and there may be mechanisms existing by which it can be secreted, so that is tubular secretion. So tubular absorption is the one which is removing the drug from the tubules, and this is happening at the level of the PCT. Okay, now net renal excretion, that means how much drug is being excreted. Since it is a combination of these processes, we can determine by a equation. So it will be filtration minus tubular reabsorption, because it has been absorbed, it has been removed, so we subtract it, then plus tubular secretion, because this is again the mechanism through which the drug is being added. So that is the net renal excretion of the drug. Now there are factors which affect these as well. Okay, so first is the filtration. Whether the drug is going to filter or how much the drug is going to filter depends on certain factors, and very important ones are plasma protein binding and renal blood flow. If the drug is bound to plasma proteins, okay, suppose the drug is bound to plasma protein, so this becomes a high molecular weight substance. We know that the plasma proteins do not filter, they are acidic as well, and the glomerular membrane has a negative charge, so it repels the plasma proteins as well. So these are not filtered. So any drug which is bound to the plasma protein, that is not going to filter. So that means the free component of the drug which is not bound to plasma protein, that is only going to filter. That means again that if the plasma protein binding is more, renal excretion of that drug will be lesser. Okay, renal blood flow will determine the hydrostatic pressure. So component, the factors which affect the glomerular filtration, one of that is hydrostatic pressure as well. So if renal blood flow increases, GFR is going to increase, then obviously the drug filtration is going to increase. Then coming to age and renal failure. See, with age this GFR continuously declines, right? And that is why the excretion of the drug, the filtration of the drug is going to decline, and same happens with renal failure. So with age and renal failure, we have to adjust the dose of the drug because it is going to accumulate in the body. Okay. Then coming to tubular absorption. How much drug is being absorbed will depend on what? Well, this tubular absorption is mainly passive process. Okay. So passive means the drug has to be lipid soluble. Okay, so if a lipid soluble drug filters, it will be reabsorbed from the tubule. So there will be back diffusion of the drug from the tubules into the blood vessel. So this is like the interstitial area, and parallelly there will be the blood vessel running. Ultimately after absorption, it will enter into the blood vessel, right? Now this fundamental is used for the excretion of the toxic drugs. Suppose there is toxicity of acidic drugs. Okay, in that case the urine pH is made alkaline. Okay, so there are syrups, say suppose alkazole is there, which will make the urine alkaline. In that case we are changing the pH of the urine, and in drug transport mechanisms we have read that like is absorbed in like medium, because in there is less ionization. This is opposite medium, acidic drug, alkaline medium, urine is pH. So in this case, there will be more ionization. Ionization means it becomes more polar, and hence it will be absorbed less, reabsorbed less from the tubules. Okay. So for acidic drug toxicity, example barbiturate toxicity, salicylate toxicity, we do forced alkaline diuresis. Basically, the pH of the urine is changed to alkaline. Okay, so that this tubular absorption is decreased. Then next is tubular secretion. How is this going on? Tubular secretion depends on certain proteins, that is organic anion transporter proteins. Organic cation transporter proteins. The name indicates that they are going to secrete the anionic and cationic drugs. Okay, so anionic transporter protein, organic anion transporter protein, organic cation transporter protein. There are other proteins as well, like P-glycoprotein, which we have discussed again in drug transport mechanisms. Okay, then since proteins are involved, okay, so there might be again competition with the drugs. If two different drugs are being secreted from the blood into the tubules and they use the same transporter protein, there will be competition between the drugs and that will affect the excretion of the drug. Again, one example of this is methotrexate and NSAIDs. Okay, in this case NSAIDs are excreted, methotrexates are not excreted, so they accumulate in the body, right? So there can be competition. Then this tubular secretion mechanism is less developed in neonates, and with infancy, within a few weeks it starts developing. So we have to be aware, because again you are giving certain drug and it is not being secreted at a particular age. Okay, so those were the mechanisms that how drug excretion via the kidney is being affected, right? Now, there is a concept known as renal clearance. Now, this concept I have explained in my another video in physiology, renal clearance. So, if you have forgotten those concepts, you please watch that video as well. In brief, I am going to tell you here what is renal clearance. Renal clearance definition is a very hypothetical concept. Okay. So, first we'll try to understand that what is happening. See, here the blood which is entering into the kidney, say suppose the plasma concentration in that blood is 10 milligram per deciliter and some amount of the drug is excreted. Now, because of excretion, the plasma concentration in the outgoing blood, it is going to be lesser. Okay, this is simple, because some is excreted, the plasma concentration is getting lesser. But renal clearance definition is little bit different. What it says is, say suppose plasma concentration is there, some amount is getting excreted. Now, say suppose the blood which is coming out, this is A plus B is equal to the total blood which is entering into the kidney, right? Now, some amount of drug has a concentration equivalent to the blood which is entering, while the other amount of drug is completely cleared of the drug. Okay, so how we define renal clearance? Renal clearance is the amount of the plasma which is completely cleared of the drug per unit time. Now that doesn't happen. None amount is completely cleared always. Actually, this is the normal concept. Okay, but the definition says something like this: the amount of the plasma which is completely cleared of the substance per unit time. Understanding? So this is a hypothetical kind of definition. And how to find out how much plasma has been cleared? See, the original plasma concentration was this only. Here also it will be 10 only, right? Here 10, here 10. So the original plasma concentration is there. You multiply it with the volume, that is the plasma which has been cleared per unit time. So this is amount. What is amount? Amount is the volume into concentration gives you the amount. That is the normal formula. Volume into concentration gives you the amount. So amount which has been removed is the amount which has entered into the urine. Amount removed from here is the amount which has entered into the urine. So what we do is, what is the amount removed? Plasma concentration into the volume of the plasma which has been cleared of the substance is equal to the urine concentration of the substance into the urine flow rate. Okay, so that is the amount, and this is also known as rate of elimination. This whole amount which has been removed per unit time, that is known as rate of elimination. Okay, now how to derive this clearance? Just remove this PC here. So clearance will be equal to rate of elimination divided by the plasma concentration. So this equation is very important. Clearance is equal to rate of elimination divided by the plasma concentration. Okay, so you just remember this: amount 1, that is the amount which has been removed, is equal to the amount 2, that is the amount which has entered into the urine. So amount is equal to volume into the concentration. So that is what we are doing. This is the volume of the plasma which has been cleared. This is the concentration concentration of the drug in the plasma. This is the urinary concentration and this is the urine flow rate. Okay, so clearance becomes, we can write this also, urine concentration into urine flow rate divided by the PC. Since this is equal to the rate of elimination, we are writing as rate of elimination divided by the PC. Now, if we take integration of this, see, this is at a particular time. Suppose we have given a particular drug whose bioavailability is 100%. That means whole drug is gone into the systemic circulation. If this is excreted over time whole drug is going to get excreted. So rate of elimination will be equal to the total dose which is eliminated. Okay, so we can write it as dose divided by the plasma concentration. So this is dose divided by the area under the curve, because plasma concentration is not 1. Plasma concentration at time 1, when you gave the drug, there will be some plasma concentration. At time 2, some drug will be eliminated. Plasma concentration is going to change. It is going to decrease. So with time, plasma concentration is decreasing. So that plasma concentration, since we have integrated, we are taking it as area under the curve. Okay, so we can draw like this. This is the change in the plasma concentration, T1, T2. Okay, so here it is some plasma concentration, and with time it is decreasing. We take this area under the curve. Why I am telling is that KDT in that chapter it has not given this equation, but Goodman-Gilman has given this equation, and this will help you in solving certain MCQs as well. Okay, so clearance is equal to rate of elimination divided by the plasma concentration, or you can also write dose divided by the area under the curve. Now remember, even though we are talking mostly about the kidney, clearance can occur in so many different organs we have seen, right? So clearance, total clearance is equal to clearance in kidney plus clearance in liver plus clearance in other organs. So that fundamental you should remember. Now coming to the last part of this video, that is kinetics of rate of elimination. Okay, now this fundamental concept you have read in physiology as well, where we talk about simple diffusion and facilitated diffusion. Simple diffusion follows linear kinetics, while facilitated diffusion follows saturation kinetics, and that is what we are calling here as first order kinetics, which is the linear kinetics, and zero order kinetics, that is the saturation kinetics. Okay, so what this first order kinetics says, or we can say linear kinetics says, that rate of elimination is directly proportional to the drug concentration. So this is the concentration of the drug. Okay, that means when the drug concentration is more, rate of elimination is more. When the drug concentration decreases, rate of elimination decreases. So it's a linear relationship. In this, a constant fraction of the drug is being excreted. Okay, so amount is changing, but constant fraction is being excreted. In zero order kinetics or the saturation kinetics or the capacity limited kinetics, what happens? Till a certain time there is increase, but after that there is saturation. That means drug concentration, even though it is increasing, rate of elimination is not changing. It is constant. See, it is constant. Here you see, as drug concentration is increasing, rate of elimination is also increasing. Here, rate of elimination is constant even with increase in the drug concentration. So in this case, constant amount is being excreted. Okay, so first order kinetics, also known as linear kinetics, zero order kinetics, also known as saturation kinetics, or also known as capacity limited kinetics. In this, constant amount is secreted. In first order, constant fraction is in this, constant amount is excreted, while in first order, constant fraction is excreted. Okay, now I have drawn this line as a straight line, but this straight line can be like this, all are straight lines, isn't it? But the relationship between the rate of elimination and drug concentration is changing, and this is determined by the slope of this line, that is known as the K. And simple mathematics, how you determine the slope of any graph like this? Simply divide y, whatever is present on the y-axis, with the x-axis. So this K, the slope, is equal to y divided by the x, is equal to rate of elimination divided by the drug concentration, right? So this is the formula for the K, that is the slope. Now here it is appearing very simplified. In your books it is given a log scale and all. That we are going to discuss in the next video when we talk about the dosing. So all equations, all the dose, how it is calculated, that I am going to discuss in the next video. Thanks for watching the video. If you liked it, do press the like button, do share the video with your friends, and don't forget to subscribe to the channel Physiology Open. Thank you.